Welcome guys. In this session we will be discussing regarding the tryptophan amino acid, how the tryptophan is metabolized, what are the special products, and what are the various clinical correlations are there with them. So the basic properties from the classification part, just to rewind that, tryptophan, fan in the name, so I can say it is aromatic, it is essential amino acid, and this tryptophan is we can say it is a hydrophobic amino acid. Hydrophobic because aromatic is hydrophobic. It contains a special ring, we can say, that is called as indole ring. So let's writing this point is contains indole ring. If you see the structure, it contains a ring and that is referred as indole ring. Indole ring. Apart from that, I want to add one more point here, and that will help in understanding one disease. See, the tryptophan is amino acid that is particularly low in corn. That is particularly low in corn. So I am writing tryptophan is low in corn. So those who are taking as a staple diet, those who are using corn, or I can say maize as their staple diet, there are chances that the tryptophan deficiency may occur. Corn or maize, those who are taking the staple diet of corn and maize, there are chances tryptophan deficiency may occur. Once we are clear with these basic properties of the tryptophan, let's see what are the special products of tryptophan we have. When it comes to the special products of tryptophan, the tryptophan, it has three special products. Tryptophan is required to make three special products. The first special product of tryptophan, it is niacin. Niacin is the name for the vitamin B3. Then the second special product of tryptophan is serotonin. Serotonin. The third special product is melatonin. There are three special products of tryptophan we have, niacin, serotonin and melatonin. So now we are going to see that how these all the three are going to be synthesized. So starting with the first one, that is the niacin synthesis. Niacin means vitamin B3. So how amino acid can convert into vitamin, and it's itself a MCQ there. The ask is which amino acid can convert into vitamin. Which amino acid can convert into vitamin? The answer will be tryptophan, because it can convert into vitamin B3. Tryptophan is a vitamin that at least tryptophan is amino acid that can convert into vitamin B3. When it comes to the reaction part, see, it is a very long pathway and it is not very important. So what is important in that entire pathway is when the tryptophan converts into niacin, what is the name of that pathway? This is one important question. And the name of that pathway is the kynurenine pathway. The name of that pathway is kynurenine pathway. The rate limiting enzyme for the kynurenine pathway is quinolinate phosphoribosyl transferase. Quinolinate phosphoribosyl transferase. That is the rate limiting enzyme for the niacin synthesis. In this reaction, we also require vitamin B6 for the quinolinate phosphoribosyl transferase. We require vitamin B6. What I can say is to make the vitamin B3, we require tryptophan. Along with that, we also require vitamin B6. Then here we can say that if you want to make 1 milligram of niacin, then it requires 60 milligram of tryptophan. 60 milligram of tryptophan, it will be converted into 1 milligram of niacin. Why this niacin is so important? See, the niacin, if there is deficiency of niacin occurs due to any reason, let's say if there is deficiency of niacin occurs, it will lead to a condition that is referred as, or that is called as pellagra. The clinical features of pellagra are very peculiar. When it comes to the clinical feature, the first symptom of pellagra, it is referred as diarrhea. The first symptom of pellagra is diarrhea. Pellagra always starts from the GI tract. Then if it is not treated, it will lead to dermatitis. And then if not treated, will lead to dementia. And ultimately, if not treated, will lead to death. So because you can see that the symptoms are starting with the letter D, diarrhea, dermatitis, dementia, death. So the pellagra is also referred as 4D disease. This pellagra is also referred as 4D disease, or sometimes is also referred as 3D disease. 4D disease or 3D disease, that is pellagra. So what are the points to be remembered for pellagra is, the first thing they ask is what is the first symptom. Pellagra always starts from GI tract. The answer is diarrhea. When the dermatitis occurs in a very peculiar manner. I will show you the image so that you will understand why this dermatitis is peculiar. Dermatitis means inflammation of the skin, right? And this inflammation that is occurring in the pellagra, it occurs in the sun exposed area. So let's see this image. So I can say that the dermatitis that is going to happen here will be having something called as the castle necklace appearance. Castle necklace appearance is very peculiar for pellagra. So these are the points to be remembered for the niacin part, right, and the pellagra. This is the first special product. Then the second special product is, let's see how the tryptophan converts into serotonin. So to convert the tryptophan into serotonin, tryptophan first will undergo a hydroxylation reaction so that it will convert into 5-hydroxy-tryptophan. The name of the enzyme is tryptophan hydroxylase. Then this tryptophan, 5-hydroxy-tryptophan, what we do is we remove the carbon dioxide. And whenever we remove the carbon dioxide, that is the decarboxylation reaction. So the name of the enzyme is tryptophan decarboxylase. And we have discussed in the earlier session that whenever we do decarboxylation, we require vitamin B6. So B6 is required. The 5-hydroxy-tryptophan now will convert into a molecule that is referred as 5-hydroxy-tryptamine. 5-hydroxy-tryptamine. This 5-hydroxy-tryptamine is the other name of serotonin. Sometimes is also written as 5-HT, 5-hydroxy-tryptamine. Right. So this is how the serotonin is synthesized. In the serotonin synthesis, the point to be remembered is that the rate limiting step of serotonin synthesis is tryptophan hydroxylase. Now, when we have this excess amount of serotonin, whenever we have the excess amount of this serotonin molecule, 5-hydroxy-tryptamine, if it is in excess, then what is going to happen with that? If in excess, then it will convert into a molecule that is referred as 5-hydroxy-indole acetic acid. That is in short written as 5-HIAA. 5-HIAA. And this 5-HIAA is a water soluble molecule, so it will come in the urine. So whenever there is excess amount of serotonin, what we are going to see in the urine is 5-HIAA. And that has a very important clinical correlation. So the clinical correlation is, there is a entity that is with the name of Carcinoid Syndrome. What is carcinoid? Is basically, carcinoid is a tumor of argentaphene cells. Carcinoid is a tumor of argentaphene cells. Now these argentaphene cells are responsible for serotonin secretion or serotonin synthesis. So if there is tumor, so I can say the 5-HT, that is the serotonin, is going to be increased because these argentaphene cells are responsible for the serotonin synthesis. So there will be excess amount of serotonin that is going to be there in the body. There is going to be the excess of serotonin in the body. Now, because when there is excess amount of serotonin, what this serotonin will do? See, serotonin is a molecule that increases the intestinal motility, that leads to vasoconstriction, right? So there will be several mixed symptoms that we are going to get. So when there is carcinoid, there is excess amount of serotonin, the bouts of serotonin will come, and the manifestation that it is going to manifest as, because it will lead to increase in the intestinal motility, so the patient will have continuous diarrhea. Continuous diarrhea is going to be there. Along with that, because there are prominent vasoconstriction will occur, And because of vasoconstriction, what happens is that the blood is going to accumulate. The vasoconstriction occurs in such a way that will occur predominantly in the extremities. So more blood will accumulate in the area of the face, and that is called as facial plethora. Now, because of facial plethora, what happens is the face of the patient looks like a red hot tomato. So that is called as flushing of face. So whenever you see these two symptoms in any patient, there is refractory diarrhea, continuous diarrhea is there, and along with that, there is the flushing of the face is there. We should always suspect carcinoid. And once you suspect the carcinoid, how to investigate this patient? We know that the excess amount of serotonin is going to convert into 5-hydroxyindole acetic acid, and that is going to present in the urine, right? So if you are suspecting carcinoid, you need to check the level of 5-hydroxyindole acetic acid. For screening, we will check in the urine, and for confirmation, we will check that in the plasma. Let's say these levels are high. It is time to the treatment. So how to treat the patient? We have to give the injection of octreotide. Octreotide is basically a somatostatin analog. What the somatostatin analog will do is, somatostatin is basically going to decrease the secretion of serotonin, right? So by doing that, the symptoms will decrease. So this is the first clinical correlation, that how the carcinoid is diagnosed is because there is excess amount of serotonin, and that will convert into 5-HIA. That is the way by which we can diagnose the carcinoid syndrome. So this is the first special product of the second special product of the tryptophan. The third special product is melatonin. The third special product of tryptophan is melatonin. So how it is done? How it is made? See, tryptophan, just now we have discussed that it can convert into 5-hydroxytryptamine, that is serotonin. 5-hydroxytryptamine, 5-HT. Now what we do is, if we add the methyl group on the 5-HT, and we know that whenever we need to add the methyl group, we will call the SAM, that is S-adenosylmethionine. S-adenosylmethionine is going to donate the methyl group, and that will be added on the serotonin. The serotonin now will convert into a molecule that is referred as melatonin. So this is how the melatonin is synthesized. Melatonin is basically a methylated form of serotonin. Melatonin should not be confused with melanin, because melanin is for the skin complexion. Melatonin is not for the skin complexion. Melatonin is found in pineal gland. And what it is going to do is, it is going to maintain the circadian rhythm, the sleep-wake cycle. It is going to maintain the circadian rhythm or the sleep-wake cycle. At a fixed time, we fall asleep. At a fixed time, most of the time, we get up from the bed automatically. That is the sleep-wake cycle, and that is regulated by the melatonin that is found in the pineal gland, or that is also called as circadian rhythm. When you travel multiple time zones across, then what happens is, there is a problem that the patient might face, that is called as jet lag. Because let's say the person is traveling from India to all the way to United States of America, then there will be a time difference of almost 12 hours, right? The time there is day, at the time there is night, so it's altogether completely opposite. So what happens is, he is unable to fall asleep on that time. So that is called as jet lag. So how to treat the jet lag? One of the way to treat the jet lag is, because the circadian rhythm is regulated by the melatonin, and what we do is, we give a drug that is a melatonin receptor agonist, right? And the name of that is Ramelteon. That is an over-the-counter drug available. So that is used in the treatment of jet lag. The treatment is Ramelteon. Ramelteon is a melatonin receptor agonist, and that works for the treatment of jet lag. So these are the three special products of tryptophan. The first one that we have discussed was was a vitamin, that was the vitamin B3, that is niacin. Then second we have discussed about the serotonin, and thirdly we have discussed about the melatonin. Apart from that, there are some other clinical correlations also that we need to understand, and then in that we need to understand is with the name of Hartnup's disease. Let's understand what is Hartnup's disease is, right? So the structural and the functional unit of kidney is nephron. Let's say this is the diagrammatic representation of nephron. Normally what happens is that in the filtrate, this is the efferent arteriole, the glomerulus and the efferent arterioles. So in the filtrate, the amino acid that comes in the filtrate, whatever amino acid that comes in the filtrate, I am writing, instead of amino acid I am writing AA. These amino acids are supposed to be absorbed back and they are supposed to be sent to the nearby capillary network. These amino acids are supposed to be absorbed back 100%, and these amino acids will be sent to the nearby capillary. So the amino acids are not going to be lost in the urine. This is the normal physiology. Now, if I divide the amino acid into several categories, one of the way by which I can divide, we have discussed in the other session, that is the classification of amino acid. In that we have discussed that the amino acid can be acidic, can be basic. Acidic amino acid, they are the negatively charged amino acid. Acidic amino acid, they are the negatively charged amino acid. The basic amino acid, they have the positive charge. And there are some amino acid which does not have any charge, they are the neutral amino acid. So if we talk about the tryptophan, tryptophan is a neutral amino acid. Tryptophan is a neutral amino acid. So what happens is when this tryptophan, which is a neutral amino acid, this tryptophan molecule will come in the filtrate. This tryptophan is also supposed to be absorbed back and supposed to be sent back all the way to the blood, nearby capillaries. To absorb this tryptophan, we have a special channel. For the neutral amino acid, we have a special channel in the proximal convoluted tubule. And the name of that channel is SLC6A19. SLC6A19. This is a special channel which is there for the absorption of the tryptophan. Now what happens is, if this channel is undergone a mutation, let's say it is not working, it is mutated, then this tryptophan absorption is not going to occur. This tryptophan molecule will remain in the nephron, and these tryptophan molecule all the way will be lost in the urine. Tryptophan lost in urine. If the tryptophan lost in the urine, this neutral amino acid is lost in the urine, this entire condition is referred as the Hartnup's disease. So if I summarize what I have discussed about Hartnup's is, I can say in that way, Hartnup is because of mutation of one channel, that is SLC6A19, and because of that the neutral amino acid tryptophan is going to be lost in the urine, right? So let's write down this point, that what is Hartnup? Due to mutation of SLC6A19, there is loss of tryptophan in urine. If there is loss of tryptophan occurs, I told you that one of the special product of tryptophan is niacin. So I can say there is a deficiency of niacin may occur, and the deficiency of niacin leads to pellagra, right? So loss of tryptophan can lead to deficiency of vitamin B3, and vitamin B3 deficiency can lead to pellagra. So if they ask that how the Hartnup disease patient is going to manifest to you, Hartnup will manifest like pellagra like symptoms. So let's write down this point, that when it comes to the clinical features of Hartnup, will be pellagra like. The symptoms will be pellagra like symptoms. So the patient will come to you in the same way, the dermatitis, the diarrhea, dermatitis, dementia is going to be there. Now it's time to investigate the patient to confirm the diagnosis, right? How to confirm the diagnosis? We need to demonstrate, to confirm the Hartnup, what we need to do is, we need to demonstrate that the tryptophan is there in the urine. If we are able to do that, yes, we can say it is Hartnup's. Now, to demonstrate the tryptophan in the urine, we have a test that is with the name of Obermeyer test. Obermeyer test is done to detect the tryptophan in the urine. Now, what is the treatment? The treatment is you need to supplement more tryptophan. This is one thing. See, the mutated channel, we cannot reverse them. Once there is mutation, it is going to remain there. So, how to overcome this situation? How to overcome is you need to give the excess tryptophan supplementation. We need to give tryptophan supplementation. Along with that, we will give vitamin B6. Because vitamin B6 is one thing that is going to help in more niacin synthesis. If you see the niacin synthesis pathway that we have discussed just now, that in that we require, if you see the rate limiting enzyme of niacin synthesis, quinolinate phosphoribosyl transferase, that requires vitamin B6. So for the treatment of Hartnup, we are going to use the vitamin B6. This is all about the Hartnups that we should know. There is a similar pathology. To the Hartnups, and the name of that pathology is called as the Drummond syndrome. Let's understand what is Drummond syndrome is. Again, it is going to occur mostly in the newborns only. Now, what happens in the newborn is, if this is the representation of the GI tract, because tryptophan is an essential amino acid, so it has to be taken in the diet. Let's say these are the tryptophan molecules. These are the tryptophan molecules. Now, when this neonate will take this tryptophan molecule, they are supposed to be absorbed in the small intestine. These tryptophan molecules are supposed to be absorbed in the small intestine. But if I say that there is a pathology in the small intestine and due to any reason, these absorption does not occur. If the tryptophan absorption does not occur, then what you can easily appreciate is the fact that the tryptophan molecule will come in the colon. Once they will come in the colon we have something called as the commensal bacteria. We have the commensal bacteria. Commensal bacteria means the non-pathological bacteria. They reside in our colon. What this commensal bacteria will do is, the tryptophan is going to react with the commensal bacteria. The commensal bacteria will ferment them. And once they will ferment them, what you are going to notice that the tryptophan molecule now will convert into blue color molecule, and that is referred as indigocyanin. That is basically a dye. So this blue color molecule now will come in the stool. This dye will come in the stool, and that will lead to blue discoloration of the diaper. So the mother will bring the child to your OPD or maybe in the emergency and saying that her child is having since birth he is having this blue colored stool, right? In the initial part we may neglect it for few days, maybe for a week altogether, and later part when it continues, the mother will bring the child, and if there is blue discoloration of the diaper, that is referred as the Drummond syndrome. The other name which is more commonly used, that is called as the blue diaper syndrome. The blue diaper syndrome. See, they are not going to use the word blue diaper syndrome in the exam because it's very obvious. So they will use the alternate name mostly in the MCQs, and that is the Drummond syndrome, right? So the Drummond syndrome occurs because of what? It occurs because of the malabsorption of the tryptophan, and that is going to reside in the colon, will convert into indigocyanin. So these are the clinical correlation of the tryptophan, right? Okay. Thank you.